you for this opportunity and thank you for being here. So my name is Sari Al Hajaj. I'm a trust graduate in trauma orthopedic in Kettering General Hospital. Today's topic is a quite common topic, which is hip fractures, neck of femur fractures, and we see them, can say every day we see at least one patient admitted with neck of femur fracture. So let's go about hip fractures. They are common, and their numbers are increasing because of population age. So over than 80% of our patients are more than 65 years old, and according to the studies, majority of the patients who sustain neck of femur fractures, they are above 65 age. Now, according to studies, they estimated the numbers of population elderly, they are doubled by the year 2050, and that will mean that neck of femur patients will be doubled by that year. Accordingly, they will say around 6 million patients will be admitted yearly with neck of femur fracture. So let's go about nice recommendation, how we approach hip fractures in hospital. First of all, it is multidisciplinary, it is a joint care. We need to involve physiotherapy, trauma orthopedic, and ortho-geriatrics, and we need to operate on them on timely manner. So in our hospitals, we need to aim within 36 hours. We need to put the patient on the table and operate on them. We need to provide proper analgesia, and that will reduce the length of stay in the hospital, and they will mobilize them early discharge, and that will free a bed, decrease the cost on the NHS. So why we did this QIP, why we had this idea. So in our daily routine, and we have enough MDT going on weekly basis, we noticed two things: that most of the patients, they are not receiving proper analgesia, so they are hardly mobilizing on day 1, day 2. And when we go back to the reason of that, they are not having proper painkillers. The second thing is on enough MDTs, we go and review all the medications, all the blood tests. We see that the investigation for bone profile, they are not ordered, or sometimes patients, they have double order for vitamin D or bone profile, repetition of orders. So let's go and speak about the NICE guidelines in our hospital. So let's go about the painkillers and analgesia. According to NICE guidelines, they say we can give paracetamol. That's the basics for every patient. We can add opioids if the patient is still in pain and needs, and there's a buprenorphine patch. Buprenorphine, because transdermal patch will sustain a painkiller through a week, over 24 hours. And there is some side effects of that, which is delirium post-op. So our hospital, what we recommend is to give small doses. It is 5 microgram per hour, and that we saw that it will help with painkillers and it will reduce the delirium post-operatively. And there was a study that's done in 2018 and was published in Geriatric Orthopedic Surgery and Rehabilitation. So what they did is they assessed the pain management for neck of femur fractures. So what they did, they divide the patients into 2 groups, one patient receiving buprenorphine patch and the other only morphine, PRN. And they noticed, they calculated how much the patient needs painkillers depending on the frequency of morphine on the other group, in both the groups. They found that buprenorphine is sufficient to provide proper analgesia for patients. They are requesting less morphine and they're mobilizing early on. And they concluded that transdermal buprenorphine is safe and effective in the management of pain following a neck of femur fractures. So why our objectives with this project? First of all, we need to improve the analgesia. We need to improve proper painkiller for patients, mobilize them early, and free a bed from the hospital. We need to order the investigations on timely manner. So we need to avoid the repetition, and we need to avoid some patients being a week, 2 weeks in the hospital with no vitamin D, with no bone profile, with no proper assessment. And yeah, of course, we need to reduce the length of stay. So what is our methodology? This was a retrospective study. We did over 4 months from November to March 2023. We used our internal hospital system, which is e-trauma, EPMA, care flow, to get all the data for patients. And what the criteria we're looking at is, are the patients getting adequate analgesia on admission? So our idea is to start optimizing the care from day 0. When the patient in ED moving to the ward, we need to make everything ready for the patients. So are they getting adequate analgesia? Are the bone protection on vitamin D investigations ordered from day 0 or not? And if needed, is vitamin D started within 72 hours? Our result, we collected 105 patients. So we are doing good on the basic treatment, which is paracetamol. Around 94%, they are getting the basic paracetamol. However, On buprenorphine patch, only half of the patient they got buprenorphine prescribed. And that's what we are doing really bad. So in the investigations, we saw that only 5% they are getting bone profile, only 6% getting B12 and folate and confusion screen, and let's say quarter of the patient they are getting vitamin D investigation. And if needed, we found like around 67% of our patients they needed vitamin D replacement, and they need to start it on vitamin D high dose replacement. So when we started that replacement, the earliest was on the 6th day of admission, and their patient they started after 20 days of admission. We give them the vitamin D, and there are only quarter of the patient they receive bone protection, which usually because either the bone investigation missed, not done, the patient is early discharge, and all these investigations are missed, so the patient did not start on bone protection. So what we found is that 90% of our patients, they are not receiving adequate analgesia. And there are half of them, they are not receiving buprenorphine patch, which is when given and compared to studies and literature, it provides proper analgesia. It gives the patient a chance to mobilize early from day one and early discharge. They can go to rehab, and that's freeing a bed. So what we did to improve this is the analgesia. So on admission, we know that SHOs and night on calls, day on calls, we miss prescribing medications, busy on call, sometimes just missed. You're having arrest in the ward, you need to go and see the patient. So you miss the medication and the patient will be admitted. Day doctor will miss it. So what we did is create a bundle and prescription system we have, EPMA. So whenever there's a neck or femur fracture, you just prescribe it there and all the medications will show. In that bundle, we added paracetamol, PR and morphine, and buprenorphine patch for 2 weeks, 5 microgram. Second thing, we did an investigation bundle to reduce the missing investigations and repetition. So on day one, on the blood form, we write hip screen. That hip screen, automatically what the lab will find, they will do 2 group and say FPC, CRP, UNEs, the normal bloods. They will add vitamin D, bone profile, and confusion screen, B12, folic acid. And at the end, we want to start vitamin D before the result. So we have a discussion with Ortho GREs and with our consultant. There was, according to the literature and their experience, no harm in giving 1 high dose of vitamin D replacement until we are waiting for the result. So if the result of vitamin D came back as normal, we're going to switch to Adcal, the normal vitamin D replacement. If it's still low, so we already started the high vitamin D, you already have the first dose on day 1. So what we learned is painkillers, analgesia. Give your patients a good pain relief. That will help them to mobilize. That will help your life be easier. And we need to improve, not only treat the fracture. We are as an orthopedics, we go there, we see a fracture, we fix it in theaters, and then we see him post-op day 1, that's it. Our job as orthopedics is done. We need to go further than that. We need to treat the bone. We need to treat bone health. That's when come the bone management and vitamin D replacement and whatever. Third thing is the investigations. So to reduce unnecessary repetition, unnecessary cost, repeating bloods, we are not sure that's done or not done, waiting and delays in the start of medication. Delays, okay, did we order it? Is it done? Is it there? No, let's do it. Let's wait for 2 days. So to reduce that, we need to order it from day 0 and improve our patient's care. Okay, these are the references. And before going to questions, so we are now in the cycle of the second cycle of our audit. We are collecting data and nearly in analysis. We did improve a lot from this results, and patients' mobility, they started from day 1. We did not see any side effects of the buprenorphine, which is delirium. It was on the lowest result. And the investigations, we are doing good on that. And that's it. Thank you. Any questions?